कोई कार्नर का पूछ रहे होगे।
So we are live now, madam.
Nilesh, there is a lot of disturbance. If you can mute the person who's creating that disturbance, otherwise the program will be difficult.
Noted, ma'am. We are live, madam. We can
We are
start.
live. We can start. Okay.
Yes, ma'am.
Okay. Just give me 1 minute. Yeah. So we are going to start now. Good afternoon, everyone. It's my pleasure to welcome everyone to this much awaited webinar of CGIFS associated with SIG Group Early Pregnancy, along with Odisha IFS and ROGS Raipur and Fetal Medicine Society of Raipur. It is going to be a big academic feast with good discussion and take home messages, and we can have the updated and evidence based tips for the management of multiple pregnancy. The main crux of this CME is to come up with practical and updated guidelines for management, and for along with SIG group we have planned for this. So now I am handing over. Thank you, ma'am, Picky ma'am, allowing us to do this webinar. And now I am requesting Picky ma'am to speak some line, two, three lines about this webinar.
Thank you so much, Dr. Anuradha, and I congratulate you and the whole society, IFS Chhattisgarh chapter, to have organized such a focused CME on such an important topic. And I welcome all the other IFS Orissa chapter, SFM Raipur chapter, along with ROGS Raipur for this important focus CME. I am actually the convener of SIG Early Pregnancy, and my co-convener is Dr. Sohani Verma. And Dr. Sohani Verma is my mentor, and my co-convener is Dr. Bindu Bajaj and Dr. Anupma Gupta. This SIG Special Interest Group Early Pregnancy has been created by the IFS so that we can focus on the special, peculiar, and particular problems pertaining to the early pregnancy period. So we've been constantly having different webinars on preconception counseling, which is very, very important, focusing on recurrent pregnancy loss, ultrasound, ectopic pregnancy. And I think multiple pregnancy is coming up with the advent of ART procedures. So we have here a collection of extremely good experts who are going to enlighten us. I'm not a fetal medicine person, so I'm sure we will be learning a lot through this webinar. And I also want to thank and welcome everyone on behalf of Dr. Pankaj Talwar and Dr. Shweta Mittal, who have sent their best wishes, and they are always there behind us. And all these programs are going to be put up on the IFS webinar, on the IFS website. So it will be, if anybody misses, we can share the link and they can check it up on IFS website. And I'm so happy to see Dr. Asha Jain and so many other stalwarts here. So my best wishes to all of you.
Thank you, ma'am. Thank you so much.
Thank you.
Thank you so much. Now, I request Dr. Sunita. Hello. Sunita, are you there?
Yes.
Sunita. Most welcome to this webinar. Now you
Very-
take over.
A very good afternoon, everyone. And in this era of 5 years, the incident of
Your
incident of
voice,
twins
your
can
voice
happen-
is not audible.
Hello, am I audible?
Your voice is not
Very
audible.
clear.
Hello. Hello, am I audible?
Volume.
Yes,
अभी
ma'am, you are
अभी
audible
अभी
now.
थोड़ा सा बढ़ाओ,
Yeah,
थोड़ा सा और
okay.
बढ़ा. साउंड बढ़ा.
Right.
हाँ.
ठीक है मैम.
हाँ.
Yes. Is it okay? Yeah. In this era of 5 years, the incidence of twins pregnancy is increasing day by day. And here we are honored to bring together the experts from across the region to share their knowledge and experiences. So we wish you all a fruitful and engaging discussion on this very important topic. And we look forward to all and
Mixie में
everyone's
चला
active participation. So without delay, we are going to start our webinar. And for the first lecture, I would like to invite a stalwart in twins pregnancy by Dr. Rama Manjari Naik, madam. She is fetal medicine consultant and expert in Shreya IVF Center and Ankura Hospital in Bhubaneswar. And she has special interest in fetal echocardiography, neurosonography, and management of complicated twins pregnancy. We welcome you, madam. And to chair the session, I would like to invite Dr. Paki Saxena, madam. She is convener SIG Early Pregnancy. We welcome you, madam. Dr. Akshay Kumar Mahapatra. He is a IFS Secretary, Odisha chapter. We welcome you, sir. Dr. Asa Jain, madam, our own RMS President, madam, and she is chairperson of Foxy Food and Drug Committee. We welcome you, madam. Dr. Harshad Ruprela, sir. He is President SFM Chhattisgarh chapter. We welcome you, sir. Thank you. Dr. Rama Manjari, madam. Madam, you are not audible. Please unmute yourself.
Okay, thank you. I'm Dr. Rama, and thank you, madam, for this kind introduction. Let me share my PPT. Is it visible, madam?
No, it is not visible. You share it.
Is it visible, madam?
Yes,
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 ma'am, it is visible.
visible.
Okay.
Yes, madam.
First of all, thank you, IFS and SFM, for inviting me here to one of the most important topic in our regular practice, that is the twin pregnancy. So, if we see the incidence in India, the incidence is 9 to 16 in 1,000 births, and the rate is comparable to that of Europe and USA. The frequency of twin birth depends upon many factors, including maternal age, parity, and use of ART. So before going to the screening part, first we need to understand the dating and confirm chronicity. So it is very important to date the pregnancy with certainty. It should be dated before 13 weeks 6 days. If the pregnancy is a spontaneous conception, then the larger of the two CRLs should be considered. And if it is beyond 14 weeks, then we should consider the fetal HC of the larger twin to date the pregnancy. And in case of IVF conception, date of embryo transfer to be considered for dating. And it is very important to confirm the chronicity, and it should be done in the first trimester itself, that is before 13 weeks 6 day. And we use these ultrasound markers like twin peak sign and lambda sign, T sign. These signs are used to, diagnose chronicity, and an ultrasound image demonstrating chronicity should always should be kept in medical record for future reference. Now, the main topic is how to screen for chromosomal abnormality in twin pregnancy. So screening for trisomy 21 in twin pregnancy should be done in the first trimester, and the most important, the most accurate method of screening for trisomy 21 in twin pregnancy is NIPT. NIPT can be offered from the 10th week, and the reporting time is 2 weeks. So within 2 weeks, we get the report and we get enough time for further investigation. But data on the screening performance using NIPT for other trisomy like trisomy 18 and 30 are limited now, and further research is needed. If NIPT is not available, then what? Yes, NIPT is not available in all part of the country. In small places, screening for trisomy 21 in the first trimester can be done with combined screening. In that, we consider NT measurement and the values of pre-VITACG and PAPE. And the alternative method is combination of only maternal age and NT. Now, in case of Vanish twin, like this, in these two images, you can see one baby is nicely growing, another in another sac, one small dead baby is there. And in the second picture, one baby is nicely seen and another only empty sac is there. This is called Vanish twin, and in this condition, only just NT in combination of maternal age should be used for risk calculation. And an alternative method is, if double marker report is there, you can consider NT, maternal age, and only free beta HCG level for risk calculation. Now, chromosomal screening for Vanish twin pregnancy can be done after waiting for at least 8 weeks from miscarriage of one twin, because in this time period, the cell-free DNA from the Vanish twin will diminish in the maternal blood circulation. So at least 8 weeks of time is needed to give the sample. Now, detection rate, if we see in singleton pregnancy, NIPT detection rate is more than 99% for trisomy 21, 99% for trisomy 13, and 97% for T18. And in case of twin pregnancy, the detection rate of NIPT is 94 to 100% for T21, which is quite high, but it is only 60% for T18 and T13. So these are all other society recommending NIPT for twins, like ACOG, ISOG, ISPD. They all agree that NIPT is the most accurate method of chromosomal screening in twin pregnancy. Now, limitation of NIPT in twin pregnancy is that in dichorionic twins, sometimes aneuploidy, sometimes discordant aneuploidy is there. In that case, if normal twin contributes a greater fetal fraction to the cell-free DNA in the maternal blood, then it can lead to false negative results. Now, NIPT has a higher failure rate in twin pregnancy, especially in dichorionic twins, IVF pregnancy, and when the maternal weight is high. And in case of single twin demise, it can make the report unreliable. Early fetal demise are more likely due to chromosomal abnormality, and this can lead to false positive NIPT reports due to the continued release of cell-free DNA from the dead twin into the maternal circulation. That's why, again, I repeat, at least 8-week time is needed to give the sample. So what about combined staining? So if NIPT is not there, we can use combined staining. The risk of trisomy 21 in monochorionic twin and thus monozygotic twin pregnancy is calculated per pregnancy based on the average risk of both. But in case of dichorionic twin, the risk is calculated per fetus. Now, detection rate of combined staining. The detection rate of combined first trimester test for trisomy, Brown syndrome may be lower in twin compared to singleton. It is 89% for single, 86% for dichorionic twin, and 87% for monochorionic twin. This is from the ISO guideline, and this is from a recent study. Now, about invasive prenatal diagnosis. Whenever there is high risk for chromosomal abnormality in the double combined screening or in the NIPT, we need to go for confirmatory test, and invasive testing is the confirmatory test to diagnose chromosomal abnormality in the fetus. And if it is a dichorionic twin pregnancy, then CVS is preferred because it provides an earlier prenatal diagnosis so that we can plan for selective termination. And selective termination, if it is done in the first trimester, the risk of fetal loss is less as compared to that done in the second trimester. So CVS is preferred in the first trimester itself. But if it is a monochorionic pregnancy, then it is a challenge. In monochorionic twin pregnancy, complicated by discordant anomaly, then amniocentesis is preferred. Why? Because if monochorionic has, I repeat, in monochorionic twin, amniocentesis is preferred. If monochronicity has been confirmed before 14 weeks of gestation and the fetus appear concordant for growth and anatomy, then only sampling one amniotic sac is enough. But if it is not concordant, if it is discordant for either growth or anatomy, it is always better to go for double amnio. Because there is a rare possibility of discordant chromosomal anomaly in the monochorionic pregnancy. Now, in amniocentesis, as you know, it is an ultrasound guided procedure. We put a small needle into the amniotic sac and we take the amniotic fluid sample. And in CVS, again, this is ultrasound guided procedure. We put a small needle and we go to the placenta and we take some placental tissue for chromosomal study. A recent study says that there is no significant difference in the fetal loss in amnio and if we compare between amnio and CVS, there is no difference. It is 3.8% in CVS and 4% in amnio. And the fetal loss depends upon depends on many factors like when it is done and what is the chronicity, the operator expertise, and that sampling technique, etc. So at the end, to summarize, prior to chromosomal screening, dating and confirmation of chronicity is very important. NIPT is the most accurate screening test for twin pregnancy. If NIPT is not available, then combined screening is the second option. The definitive test to assess fetal chromosomal aneuploidy is invasive testing, that is CVS, done in first trimester, amnio, done in second trimester. In dichorionic pregnancy, CVS is preferred. It should be done in the first trimester. In monochorionic twin, amniocentesis is preferred. So thank you. Thank you for your kind attention.
Thank you, ma'am, for a very elaborate and crisp lecture. And your lecture is very informative because we always face difficulties in dealing with twin pregnancies. Patient come with the reports of dual marker test, abnormal reports, or NIPT abnormal reports. Then it is always confusing how to counsel the patient and how to suggest a good test for them, because NIPT is relatively expensive. So we
Yes.
cannot advise to many more patients.
Yes, it is not available also
It is
everywhere.
not available in smaller places also, ma'am. So your lecture is very nice and very
Thank you, madam.
informative.
Thank you, madam.
Thank you, Dr.
Asana,
Rama.
thank
So
you.
that was really very crisp, very, very crisp. And the pointers that you gave about what has to be seen in the first trimester scan is something that everybody, even those who are not doing scans, should read in their reports and correlate with images, which you have demonstrated so well. Because you just read the report, you don't see the images, and your mental picture is absolutely not there. And as for NIPT, the rates, it used to be 35,000 at one time. Today you can get it done for 6,000 rupees. So I think a patient of IVF, a patient of twins who's going to, have a lot of expenditure anyways.
Yes.
You can't stop that. You will have to do every 2 weeks, you're going to do a scan. Every 4 weeks, you're going to do a scan. So expenses are there, and that has to be expected and not missed. That's, better do whatever is possible and you think proper. Because these days, with the number of children going down, having abnormal kids is a big liability,
Yes.
a very big liability. So I think compared to that, and compared to the fact that if you miss something, then what will be your liability? I think the cost doesn't really count. So we need to, all us gynecologists, we need to look at the images and correlate with the report, whether the section is right. We may not do it ourselves, but we need to see the report, whether it's a standardized image. Only then our reporting and the outcome will match. So thank you so much, Dr. Rama.
Thank
It
you
was
so
great
much.
listening to you.
I think
There is
I think one thing we have left out. If one twin pregnancy, one fetus is demised, then how to proceed? Then how to interpret the NIPT report?
That's right, madam. If it is in the first trimester, we can use only free beta HCG because PAPE is not used in this case, because some studies, some recent studies, they are saying if we compare between singleton beta HCG PAPE in the first trimester to twin with vanished fetus, the level of beta HCG are same in both the condition, but level of PAPE is more. That's why PAPE should not be considered. Only beta HCG can be considered. But if you are not advising double marker, then it's okay. Leave for at least 8 weeks so that the DNA of the dead fetus will be washed out from the maternal blood. And after 8 weeks, we can advise for screening.
Okay. Okay. Right.
Ma'am, I have one question. Like NIPT, how they give the reports, like a singleton pregnancy only, or what? Means how if there is any abnormality in that, then we have to go for further testing, CVS
It
or
will,
amnio.
madam, it will come as high risk or low risk like that. So
Yeah.
if it is low risk, we are happy. If it is high risk, we
Yeah.
have to go for invasive testing.
So it will be a singleton report, like as a singleton we get the report, it will be the same as for
It
twins
is,
also.
yeah, it is like that. But we have to go for
Yeah.
double amnio or double CVS like that.
Yeah.
We have
After
to
that.
examine both the babies.
Yeah.
Okay. Now second session will have
Thank you.
specifically on NIPT. So our doubt will be clear more. Thank you, ma'am. Thank you so much.
Thank you so much.
Thank you, ma'am. It was a very wonderful lecture. And now, moving forward, we will have a more clear view on NIPT in twins, current concepts in special scenario. For this, I would like to invite Dr. Purvi Agrawal. She is a renowned fetal medicine consultant in Raipur and director of Krishna Fetal Medicine Center. We welcome you, Dr. Purvi.
Thank you so much.
And to chair the session, I would like to invite Dr. Monica Pathak, madam. She is president of Raipur Ops and Gynae Society presently, and she is treasurer of RMS. Dr. Anuradha Tibriwal, she is secretary IFS Chhattisgarh chapter and secretary ROX. Dr. Padmalaya Thakur, he is a treasurer IFS Odisha chapter, and Dr. Sujata Pradhan, she is a joint secretary Odisha chapter IFS. We welcome you all. Please, I welcome
Thank you.
Dr. Purvi, and please go ahead.
I'll start.
Yeah, you can start.
Good evening, everyone. At the outset, I would like to thank Anuradha ma'am and SFM with IFS Society Raipur for giving me this wonderful opportunity. Today, I'll be discussing about NIPT in twins. I'll be discussing about some special scenarios which we face in our day-to-day practice. So, first and foremost, Rama ma'am did half of my work. She made it clear that NIPT, according to ISWOC 2025, is the first test, is the best test which should be advised for screening for twins. Now, this NIPT, we have to understand, has a very good sensitivity, but the very good sensitivity is limited to T21 only. So let's understand the basic of NIPT first. So this is the uterus, this is the fetus, this is the placenta. Now, when we say NIPT, we say cell-free fetal DNA. Now, we have to understand it is not exactly the fetal DNA. It is DNA from the placenta. So when the placenta, specifically cytotrophoblasts, they release DNA, this DNA, which is fragmented and is not inside the cell, are being read, and this DNA is being analyzed in the form of NIPT reports. Now, once we get the report, then we label it as low risk or high risk. If at all it is low risk, we are very happy, we are good to go. If at all it is high risk, we subject the patients further to invasive testing. Now, keeping this scenario aside, when you know the twins are normal, everything is normal, NIPT is normal, let's discuss about some scenarios which are not very ideal. Now, first scenario, we have a DCDA, dichorionic diamniotic live intrauterine gestation. Both the fetuses are very well, both the fetuses are live, both the fetuses are looking good. So in this scenario, what do? NIPT should be done. NIPT is much better than any other screening test. And this is the screening test of choice. So in dichorionic diamniotic live intrauterine gestation, we do NIPT as the first line of screening. It has a very good negative predictive value. That means if my test is negative, there is very less chance that the fetus will turn out to be positive. Scenario 2, where we have a monochorionic twin intrauterine gestation. Now, either it is a monochorionic monoamniotic or a monochorionic diamniotic. In both the scenarios, we have NIPT and it should be done. Why? Because both are live, both are looking fairly good, and both of them will have a same genetic makeup. So it should be done. It is much better than any other screening test which is available. Anyway, the incidence, prevalence of trisomy 21 or any other aneuploidy is extremely rare in monochorionics. So unlikely you will land up in a positive result. But if that happens, you need to do an invasive testing further on. Scenario 3, we have triplets or higher order gestation. We have TCTA, DCTA, MCTA, MCMA, any kind of triplets or any higher order gestation. What do we do in these kids? So in this babies, we do not have any data yet. We don't have data, we should not do it. It is the need of an hour because TwinsMate is validated. The next step is making it validated in triplets or higher order pregnancies. Why is it not validated till now is we need more studies. For more studies, we need more triplets. More triplets are less common in the world which is outside India because the ART is much more regulated outside India. So incidence of triplet is less. Therefore, NIPT is done less. Therefore, we have less data and therefore the validation is still not available for triplet pregnancy or a higher order pregnancy. Next, we just discussed NIPT in twins with one twin which has vanished or has died early in the pregnancy. In this cases, we need a period of at least 8 weeks if precisely you know when the fetus passed away. If at all you don't know, then the day which you have scanned and you see the fetus is not there, you can wait for 8 weeks and then do NIPT to be on the safer side. Now, what happens in this case? The fetus is gone, but the placenta might still be there. So that placenta will still give blood. Now, if at all you are telling the lab ki one fetus is only there, the other fetus is dead, but we have two placenta. Two placenta is giving DNA. So we have a high false positive. The machine will think we have only one fetus, but DNA is coming for two fetuses. So high likely chance that the result will be false positive. But if the result is negative, we are okay. Because high DNA maybe if the result is coming normal, we are okay. That means the report is absolutely normal. Invasive, anyway we have to do if it comes positive. So keep a window of 8 weeks. Uske baad NIPT kariye. If it comes as positive, you need to do an invasive. It comes back as negative, we are okay. Scenario 5, in which we have done a fetal reduction in a triplet or a higher order pregnancy. Now, There is no data yet, same as triplet. जब triplet में नहीं था, even if we reduce, we don't have a data. Moreover, when we reduce, the CRL is still left. So it is not done till now. Too many DNAs are there. So there's DNA of 2 live, mother ka DNA, dead fetus ka DNA. If at all it is a donor, then donor DNA. 5 DNA is very difficult for the machine to interpret. Next scenario, DCDA twins with one twin having an abnormality in USG. So please understand this. If at all there is at any point of time abnormality in USG, you have to think outside the box of T21. Starting of the presentation, I told it is a very good test, but it is limited to T21 only. And when you have any ultrasound abnormality, be it a soft marker for T21 itself, you have to now think of deletions and duplications. Deletions and duplications still is not validated in NIPT as the positive predictive value is very low. Now, when you are thinking anything apart from T21, you have to go ahead and do a chromosomal microarray or a whole exome sequencing. Any abnormality in USG, please go ahead with invasive testing. Now, there is one small catch in T21 NIPT also. NIPT still cannot detect isochromosomes and Robertsonian translocation type of Downs. So if at all you have any mother or a parent in which they have a balanced translocation and they are resulting in a Downs baby, NIPT might not be the best choice of screening in the next pregnancy. Ek Downs ho gaya, mother or father has an abnormal karyotype, go ahead and do an invasive testing in the next pregnancy. Now, if NIPT for 13 and 18, so the sensitivity of NIPT in 13 and 18 is now reaching at par with T21. It is still not 99.9, but it is trying to reach at par. But for twins, it has a lower sensitivity. So 13-18 ke liye, the dependency has less. But luckily, we have markers for chromosomal trisomy 13 and trisomy 18. So if we have USG markers, anyway, we will go and do an invasive testing. And it is lethal. So these babies will not have a morbidity because it's lethal, unlike Downs, which has a very big morbidity. Now, NIPT for sex chromosome in twins. So sex chromosomes in general is not to be done yet. The sensitivity is low and the false positive rate is high. That means if at all your report is positive, more likely it will be false. Why? Because it cannot differentiate between the mother DNA, the placenta DNA. Moreover, the mothers can sometimes be mosaic. The placenta can sometimes be mosaic. And mosaic for X and Y chromosome is more high than for the other autosomes. Singleton also, as of now, for sex chromosome, NIPT is not recommended. NIPT plus, the new thing which the labs are promoting for microdeletion. So microdeletion in itself, it has less positive predictive value. Now we have to understand microdeletions are rare diseases. Rare diseases may, if the labs are quoting that the positive predictive value is only 50%, my detection even becomes less. For example, if I have an incidence of 2 in 1 lakh for a rare disease, now it is telling that it can detect only 50%. Though diseases may, though patients may only one it is detecting, then how can I rely on these conditions? So ultrasound marker, then go for invasive is the best choice. Rare diseases should be having a good positive predictive value. In twins, it is even less than singleton. So very last studies are there to validate, and therefore it should have restriction. Now, twins with discordant nuchal translucency, in this case, until and unless the nuchal translucency is normal, that is less than 95th centile for that particular gestation and CRL, it seems to be a good option. The moment it is high nuchal translucency, don't do it because it becomes a USG marker. Once you get a USG marker, you are not going to do it. So it is just for screening, right? Just for screening of T21. A high nuchal translucency can be associated with other syndromes as well. Now, twins with discordant CRL. If we have a discordant CRL, are we looking at an early FGR? Now, early FGR has a spectrum of causes. We cannot just be blaming everything on Downs. So, when it is considered as discordant, when the CRL discordance is more than 10% between each fetuses. So in this condition, invasive testing is the testing of choice. So if it is more than 10 or equal to 10%, you have to go for invasive testing. NIPT in donor egg and we have twins, too many DNAs again, still it is a proof test. So you can do it, but the false positive rates are high. NIPT with low fetal fraction. Now you have to understand, if at all fetal fraction is being given, it also is a method to tell that the lab is doing a correct job. A fetal fraction, if low and given the report, the lab might not be correct and it might be a time to change the lab. So accredited lab only will have a cutoff of fetal fraction. It is also a quality control for the labs. Minimum is 4%, but some labs can vary from 2 to 5%. Positive predictive value is dependent on fetal fraction. Jitna acha fetal fraction, utna acha positive predictive value. Longer transit can reduce the fetal fraction. So make sure if you are taking a sample today, it reaches the lab in another 1 or 2 days. The more longer the transit, the less the fetal DNA will be there. In early gestation, you can get a low fetal fraction. Mosaic are the cases where the fetal fraction can be low, where the placenta is normal, but the baby is affected. Now, this is very rare, but it still can happen. Ki placenta ka DNA was normal, but the baby is still affected. So this is mosaic placenta and mosaic fetus. Now, low fetal fraction and no call is almost the same. A lab can say no call, a lab can say low fetal fraction. So no call will be in 1 to 3% of your reports. Causes are maternal adiposity. In ART में estradiol ज़्यादा रहता है because we give external estradiol and they can result in placental dysfunction. Heparin will cause dilution of the blood. That's why the DNA which we get might be less. Placenta, if at all there is a preeclampsia or GDM, there can be placental dysfunction. Fetal aneuploidies, they have less cells because anyway their aneuploidy, the placenta is not good. Abnormal placenta, twins, triploidy, all these babies can have no call results. So what do you do in no call result? You repeat the test. Again, 50% chance that it might come as no call. Now, when you have a no call or you have a low fetal fraction, you have to understand that aneuploidy ka chance will increase because aneuploidy is also a reason for a no call. So if aneuploidy chance increases, you have to go for a definitive test. Moreover, the patient trust reduces. Now the patient will be like, better to get an invasive testing done. Definitive test should be considered in these cases. Now, low molecular weight heparin may lower the fetal fraction by dilution. So what happens? The free fetal DNA divided by the total cell-free fetal DNA. So total cell-free DNA decreases. So इसमें क्या होता है? The ratio decreases. Now the analysis is not based on this diluted blood. They need a whole blood. So in these cases, it is often recommended to draw the blood just before giving the heparin injection to reduce the potential interference. Now, DCDA twins for sickle status. For sickle status, it is not so sensitive. It is not widely available in India. So still for us, we have to go for invasive testing. DCDA twin for Rh negative pregnancy. Now, Rh negative pregnancy, you are looking for Rh positive fetus. So if only both of the babies have same blood group, then it makes sense. And there is no way to know that either one of them is having positive or negative, because if both of them are negative, then only it works. If one of them is positive, the reports will not be correct. Now, NIPT before doing first trimester USG. So in these conditions, it is a very well test. Now, NIPT can be done after 9 weeks, but first trimester USG, we usually do it around 12 weeks. But in this condition, what happens? Now, if I am doing a scan, or if anyone else is doing a scan, and you already have an NIPT report, I might be a little biased. So the best time, according to me, I would say is just after I finish my NT scan or an early anomaly scan. So for me, I don't know if I'll be biased. I have not faced that scenario, but I feel doing it after the scan makes much more sense. Next scenario, NIPT after a blood transfusion in mother. So in blood transfusion in mother, you have to understand that 4 weeks time we need till the time that dilutional effect of the blood is gone. And moreover, whenever there is some external DNA, the machine analysis again gets a little not so great. So what happens? You wait for 4 weeks. the blood will get rotated and then you can do the test. NIPT with maternal fibroid. So larger fibroids can have chromosomal aberrations. So that's why it is not so sensitive as it is sensitive without fibroid. So big fibroids, please be cautious. NIPT with maternal malignancy, they have very highly false positive because the malignancy itself is replicating. There are too many DNAs and they can have the same. So for example, I did NIPT, it came out to be positive for some random chromosome 1, which is almost always never seen because they have early pregnancy loss. Then I repeat the NIPT. Again, it is coming for chromosome number 1. So these things are a little more indicative that the mother might have some problem. So go and look for fibroids, maybe go and look for maternal malignancy, maybe. But if at all you're getting the same report again and again, you have to search more. Now with maternal malignancy, the false positive is high because my chromosome number 1 was never trisomy, but report might come as false positive high. Now, NIPT is normal in the first trimester, and now I'm finding something in ultrasound in second trimester. Now, in this cases, again, you have to understand an ultrasound marker is thinking outside the box for trisomy 21. We might be dealing with micro deletions or duplications now. And pre-test counseling before NIPT therefore must be done because the patient will come and he will tell that my NIPT was normal. Now, how can you tell me to go for invasive testing? So you have to tell them the limitations of NIPT and then go ahead. Now, these are my scenarios. I just want you to take a look how to read the NIPT report. Now, first, you will get reports like this that no aneuploidy was detected. So chromosomes, the mainly one which we want to see is 21, 18 and 13. Sex chromosome also I will not advise to see here. Now, you have to look for Z scores. Now, what is Z score? This is a Z score. This curve we have been seeing from MBBS. So, a 0 -3 to +3 is the maximum Z score which you should be seeing. So for example, in this report, my Z score was 1.8. So it is good. More variation +3 se zyada, yeah, more variation -3 se zyada should not be entertained. And in these cases, if you have a Z score of very high or very low, please go ahead and do an invasive testing. Now see here also, in sex chromosomal abnormalities also, they have not written a Z score because it is still not validated. Now, sensitivity also should be given by the lab. So as you can see, they are giving 13, 18 and 21 ka 90%, and then sex chromosome again becomes 90, 93, 93. And for the other rare autosomes, it is even less. Some of them are even in the range of 70s. So whole autosomes ka NIPT still does not make a sense. Please be limited to 21, maximum 18 and 13. Now, there are some reports in which they give intermediate result also. Now, this was the first time I was seeing this report and it was a very recent report, so I thought I'll put it up. Intermediate usually is not given by the labs until and unless they are not sure about the report. Either it should be low risk or a high risk. If you face intermediate report, please go for invasive testing. A summary of screening, the lowest is age, sensitivity wise, lowest is age, then is your double marker, then is quadruple marker, then is only ultrasound, then is ultrasound plus double marker, then is ultrasound plus NIPT. Now, if a patient has so good money, they can even afford a double marker. What I'll know in double marker, I'll know the HCG and PAPE. Now, once I get these, I might be more vigilant looking for FGR and preeclampsia in the future. Might not add to my screening, but might add somewhere in the pregnancy surveillance. The best thing is to do a USG plus NIPT plus double marker plus PLGF. I mean, why not? So take home messages, very important to determine chorionicity. NIPT is very highly, but only sensitive for T21. Cafeteria approach of screening should be there. Pre-test counseling should be done. NIPT cannot replace invasive testing still, and NIPT can never replace ultrasound. So a cafeteria approach from the doctor to the patient is what we need. Thank you so much.
Wonderful. It was very, very nice talk. I must say, congratulate Purvi. You have given a crisp and very clinical approach to every different case scenarios we could have imagined. Very nice. And I must say, you have always been one of the very approachable fetal medicine expert in Raipur we have.
Thank you.
That was very nice talk.
Thank you, Dr. Purvi. Really, you have touched the practical scenarios when we see the report and we are confused how to proceed. So I think after listening you, all the confusions and all the doubts is over. Now we can read the report NIPT properly.
Yeah.
Thank you so much.
Very
Thank you,
crisp
thank you
talk,
so much.
Purvi. Very nice talk.
Thank you, ma'am.
I must congratulate you.
Thank you,
Your
ma'am.
case-based scenarios are very wonderful.
Thank you so
Yeah.
much. Thank you.
Thank you, Purvi. I have
Thank
a
you.
question
Thank
actually.
you, thank
I'll
you
take
so
this.
much.
I'll take this opportunity to IFS team for giving us this opportunity to be a part of this wonderful webinar. Thank you, Anuradha. Thank you,
Thank
IFS
you,
team.
ma'am. It's a
Thank you so
combined
much.
effort. So we
Yeah,
have
I
done
know, but
combinedly.
it was
Thank you.
a good collaboration of all the
Yeah,
societies.
yeah.
We must
Thank
promote
you.
such more activities.
Such activities. Yeah, ma'am. Thank you, ma'am. Thank you
Thank
so
you.
much.
Thank you.
Uh,
Thank you,
uh,
Purvi. Thank
Thank
you. Purvi, just a question. How early can we go for NIPT? As you tell ki there is a bias. Other than that, is there any difference in fetal fraction or something if we do it
Yes,
before
ma'am.
12 weeks?
Earlier we do the less fetal fraction. It is validated from 9 weeks. Best time is to do is 12 weeks, I feel, ma'am.
Thank you. Thank you. It was a
Thank you.
wonderful lecture, Purvi, very principal and very clear.
Thank you, ma'am.
And moving forward for our next session, next lecture, this is on guidelines-based twins pregnancy management. So let us revise the guidelines. And for this, I would like to invite Dr. Preeti Dubey, madam. She is the founder secretary of Society of Fetal Medicine Odisha chapter. She is executive member of SFM 2024, core committee member of various projects under NHM, and director of Family Welfare Odisha, recipient of Amarendra Nath Dan Prize for Best Paper in Maternal and Child Healthcare by FOXI 2012. I welcome you, madam. And to chair the session, I would like to invite Dr. Veronica Huel, madam. She is Joint Secretary, Raipur Ops and Gynae Society, past Secretary, IFS Chhattisgarh Chapter. Dr. Shalini Jain, madam, she is Secretary, RMS Raipur. And Dr. Surendra Mohanty, renowned IVF specialist in Odisha. And Dr. Sunita Ganul, myself. So, over to you, Dr. Preeti Dubey, madam. We welcome you, madam.
Good evening, everyone. Is my slide visible?
Yes,
Hello?
madam. Yes,
Yes,
it is
ma'am.
visible.
Yes, ma'am. It's
madam.
visible.
It is visible.
So thank you for this opportunity. I'm extremely thankful to Dr. Anuradha Madam and Dr. Akshay Bhai from Odisha for this opportunity. So my discussion will be on guidelines-based twin pregnancy management. So how we will manage the twin pregnancy as per guideline. So before knowing the management, how we will manage the thing, we need to know what is the chorionicity. The single important thing that we have to know is the chorionicity. It's not moving, I think. Is it moving? Sorry. Is it moving? Yeah.
Yes,
So
yes, madam. Now it is moving.
when it comes to chorionicity, it could be dizygous, where two eggs fertilize.
I think there is some network problem with this.
Hello.
Dr. Anuradha, I think there is a network issue. I think we can tell the.
Okay.
Madam, you are not audible. Please unmute yours.
Hello.
Madam, please unmute.
Hello, is this
Ah,
okay?
yes, madam. Now
You're
audible.
muted. Now
Yes,
it is
yes,
now.
madam.
So either it could be digygous or monozygous. The digygous could be either DCDA twin with separate placental implantation.
Your slides are not visible, ma'am. You are visible now. Earlier you were right, ma'am. Yeah. Yes, yes. It is visible now. Now you start, ma'am.
Should I start from here?
Yeah.
So the entire thing based on ISWAP practice guidelines. And first thing we need to know about the chorionicity. So chorionicity is either from a dizygotic twin or a monozygotic twin. Dizygotic twin, when the two sperm fuses with two eggs, giving rise to two separate zygote. So these DCDA twin, and they will either have a separate placenta implanted on different walls, or they could have a fused placenta where both the placenta are implanted on the same uterine wall. Similarly, we have monozygous, that means single egg fused with single sperm, and we have single zygote. They can have either early egg splitting, which is between day 1 to day 3, which gives rise to DCDA twin, either of separate placenta or fused placenta, or it could be a late egg splitting between day 4 to day 7. It is MCDA twin. Between day 8 to 12, it is monochorionic, monoamniotic twin. And if it is day 13 and beyond, it is lead to conjoined twin. So what is chorionicity? When we comes to chorionicity, when it is a monochorionic twin, we see a single T-shaped structure, that is only the amnion of both the placenta. So you can see this T shape, it is for monochorionic placenta. But when it comes to dichorionic, when the placenta are in close approximation in the same wall, they form a hump-like structure, and that is nothing but a T sign. And that is known as dichorionic diamniotic placenta. So that is also known as peak sign, and whenever we see a twin peak sign, we could easily differentiate it from the monochorionic or the dichorionic one. Now coming to the label, when we see any anomaly or anything, we need to know which one is the twin 1, which one is the twin 2. So the one which is near to the cervix is always, we label it as twin 1. The other one is the twin 2. So they have usually they have two type of orientation. Either it could be a left-right orientation, or it could be a cephalic or the caudal orientation as per mother position. So the left-right orientation is very common, and it is seen in 85% of the cases, whereas the cephalad and caudal type of orientation is seen in 15% of the cases. So now the question arises, the twin which I have labeled 1, will it deliver as first? Yes, it should deliver first. But in 1% of the cases, there is one phenomenon called as perinatal switch phenomenon, where the fetus A may not be delivered first. That we need to keep it in our mind. Now coming to the management. When we come to the first trimester, when we see the first trimester twins, we have to look after differentiating it from DCDA or MCDA. what normally we see. When we see a twin, we see whether they are concordant or discordant. Concordant means they are of equal size, equal NT, everything within normal limit. What about the discordant one? Discordant is either it's discordant in CRL, or there is discordant in NT, or they are discordant for anomaly. These are the possibility we get when we see the twins in the first trimester. So like how Dr. Rama has already told, what is more important to date the pregnancy? If it is IVF pregnancy or ART pregnancy, we usually use the BT date or the ET date. But when they naturally conceived, they done by using larger CRL. Always we make this rule that dating has to be done by taking larger CRL. Now the aneuploidy screening, as already discussed, I'm not going to go in detail. We are doing it as Dr. Rama and Dr. Apurva has explained me. So now coming to the screen positivity, that also Rama has explained that in monochorionic twins, we have to do amniocentesis should be preferred over the chorionic villus sampling. These are the biometry which we take as per anatomical parameter as per ISO guideline. Now, care pathways beyond first trimester. If we see in the first trimester that this is a discordant DCDA, discordant for anomaly. Discordant for anomaly means one fetus is normal, fetus is having some anomaly. So we have to know that what is that anomaly, whether it is lethal or it is going to improve after some time. So if it is lethal, we can do selective fetal reduction. Suppose we have seen a DCDA twin with one fetus having anencephaly. We know that anencephaly is a lethal anomaly. So we need to do fetal reduction, because if we don't do fetal reduction at this point of gestation, this anencephaly fetus will have polyhydramnios as the gestation age advances, and it will not allow other baby to grow. So any lethal anomaly which has been seen in the first trimester needs selective fetal reduction. Then second is discordant for nuchal translucency. If there is a discordant nuchal translucency and something which is very big that needs further evaluation, and if needed, we need to do intervention. Last is the discordancy in CRL. So as I have already discussed, we have to take always the larger CRL, and then we need to monitor these babies very frequently. Similarly, when it comes to discordant MCDA, there are also these three possibilities. Discordant for anomaly. If there is a discordant for anomaly in monochorionic diamniotic twin, we cannot do fetal reduction because both the twins are having a sharing placenta. If you will inject one KCL to this baby, the KCL will traverse through the placenta to the nearby baby. So we don't do, so what we do, we have to wait for those babies till 16 weeks for doing radio frequency ablation or any coagulation procedure, cord coagulation procedure. If discordancy, we need to follow this patient with genetic testing. And if there is a CRL discordance, we have to monitor these babies for selective FGR, which is very common in monochorionic twins. So follow-up protocol. How do we usually follow up these babies? If they are dichorionic, we have to first see between anti-scan at 11 to 13 weeks, 6 days, where dating, labeling, chorionicity and screening for trisomy 21 has to be done. Followed again at anomaly scan, that is between 20 to 24 weeks, where we can see the detailed anatomy, biometry, fetal amniotic fluid volume, and cervical length has to be reassessed. 4 weekly till the baby deliver, we need to monitor for fetal growth, amniotic fluid volume, and the fetal Doppler, and we have to deliver the baby safely at 36 weeks. What about the monochorionic twin? The monochorionic twin are first seen at 11 to 14 weeks for the same dating, labeling, chorionicity, and for screening. then again babies are seen at 16 weeks, because the early complications, which are very common in monochorionic twin, are the spontaneous abortions, single fetal demise, congenital anomalies, selective fetal growth restriction, growth discordance, twin-to-twin transfusion syndrome, twin reverse arterial perfusion, twin anemia polycythemia syndrome. These complications in monochorionic twins are very unique, and we need to know and we need to understand why we need to see monochorionic twin pregnancy so frequently. So from 16 weeks onwards, we need to see these fetuses every 2 weekly. So these are the 3 care which we provide to the pregnant women. First one is the low risk routine care. What is this low risk routine care? When there is everything is concordant, CRL, NT, and the anomaly, all are concordant. There is no anomaly, CRL and NT are concordant. Then we routinely monitor this MCDA twin 2 weekly and this DCDA twin 4 weekly. If there is DCDA discordant for CRL or NT or MCDA anomaly or the monochorionic monoamniotic twins, we monitor these very closely. And the one which needs immediate care is the MCDA twin with discordant NT, trap sequence, and DCDA baby with major anomalies. So in the second trimester twin, while we follow this, what are the things we need to look for in every scan? So as per Quintero classification, it is very easy to remember all these 4 points, because Quintero stage 1 is oligopoly sequence. So what we see, the Leica, the number stage, Quintero stage 2 is donor bladder, Norsin. So what we need to evaluate is the bladder. Then third thing is absent or end diastolic flow in the umbilical Doppler. So we need to see the Doppler. And the fourth is the heart to see for any cardiomyopathy that is related to non-human fetal hydrops or due to hyperdynamic circulation. So these are the 4 things that we need to monitor weekly in case of monochorionic twin. What about discordance in monochorionic twin? One is two out those 2 sacs, when one sac is normal and the other sac is oligo or reduced Leica. What are the possibilities? It could be anomalies, bilateral renal agenesis or bilateral MCDK or any autosomal recessive polycystic kidney disease. These are the common things where there is nil Leica or reduced Leica in one baby and normal Leica in the other baby. Second common is selective fetal growth restriction. We know that small baby will urinate less and will lead to oligo or reduced Leica. And third possibility could be PROM. If there is a PROM of the first twin, the second twin sac will be normal Leica and the first twin will have oligo reduced Leica. Second combination is normal and polyhydramnios. Normal and poly, again, same. First condition is anomalies. Anomalies, because the anomalies which can cause hyperdynamic circulation, like any type of sacrococcygeal teratoma, placenta, choriohemangioma, whatever lesion or these lung masses like CCAM, whichever will give the hyperdynamic circulation will lead to polyhydramnios. Any abnormality in the gastrointestinal tract from the mouth, I mean from the teeth fluid, anal aphasia, any obstruction, whether it is tracheoesophageal fistula, whether it is stomach, double bowel sign or the absent stomach, everything will lead to single sac polyhydramnios and a normal sac in the other. So we have to see for the close surveillance for the evolving problem, we have to rule out anomalies. And the last sequence is polyhydramnios or the oligohydramnios sequence. And that is more commonly we see in twin-to-twin transfusion syndrome. So in twin-to-twin transfusion syndrome, this monochorionic twin complication, the percentage of growth discordance, that is selective fetal growth restriction, is 14%. Twin-to-twin transfusion sequence is 9%. Discordant for anomalies 10%. TRAP is 2%. TAP is 1%, and the cord insertion, different types of cord insertion, like variation and the Doppler abnormalities we are seeing in all types of monochorionic twin complication. The most important thing what we should know is all the thing which happens in monochorionic complication, that is primarily because of placental and vascular causes, which is responsible for 26% of the cases. So it is a twin-to-twin transfusion syndrome. As I have already discussed, in twin-to-twin transfusion syndrome, we have Quintero staging, and which is based on Leica bladder, Doppler hydrox, and intrauterine fetal demise. So in Leica, we have to see for whether there is oligopolysequence, or that is known as TOPS twin oligopolysequence, bladder present in the recipient, absent in the donor, Doppler, critically abnormal Doppler, presence of hydrox, or single IUFD. These are the 5 stages. It has a natural history, and the rate progression is variable. Acute TTTS can happen over a few days. So that is the same reason why we monitor these babies so frequently, 2 weekly. So the patient will, at 34 weeks, the patient has left our clinic. At 36 weeks, the patient has come with tightness of abdomen. When we saw, it was TTTS, but because it was 36 weeks, we immediately delivered the baby. Both the babies were 1.9 kg and they were safe. So acute TTTS can occur over a very small span of time. So we need to monitor these babies every 2 weekly. So what about the management? Stage 1, that is TOPS, the twin oligopolysequence, at any gestational age, there is 30% chances that with no intervention, this baby will improve. But 50 to 70% of these babies will progress rapidly. So we have to do close surveillance monitoring. Stage 2, more than 26 weeks, then we can go for serial amnioreduction if we don't have facility, or we can go for selective feticide by umbilical cord coagulation or by RFA. In stage 3, stage 2, less than 26 weeks, and stage 3 and 4, laser is the ideal. Selective feticide by umbilical cord coagulation or RFA is kept as an alternative. Next, come to selective fetal growth restriction, which is common in monochorionic twin. In the census, which has provided one solitary finding, that is one of the baby with fetal weight less than 3rd centile is the sole criteria to diagnose selective FGR. The contributory factors are at least 2 out of these 4. That is, estimated fetal weight of the one twin is less than 10 centile, or abdominal circumference of one twin is less than 10 centile, or estimated fetal weight discordance is more than 25 percentile, or umbilical PI of the small twin is more than 95 percentile. So out of 4, if these 2 are present, then we can call it as selective FGR, that is fetal growth restriction. There are 3 types: type 1, type 2, and type 3. Type 1 is when systolic flow is positive. We have to do conservative management. We need to do weekly Doppler to monitor this baby. Type either end-diastolic flow will be absent or reversed. We need to do selective termination. And type 3, we have limited evidence, and it is totally hypothetical. I think there is cyclical change of the positive and absent and reversed way. So I don't think anybody has seen this type 3, and they have very limited evidence for type 3 FGR. Selective FGR option, either we can do laser for dichlorinization of both the fetuses, or we can do bipolar cord coagulation, the best radio frequency ablation with a very good outcome. Next in the complication is the TAP sequence, that is twin anemia polycythemia sequence. So when we frequently monitor the baby every 2 weekly, if there is inter-twin difference in MCA, middle cerebral artery peak systolic velocity more than 0.5 mom, we diagnose it as twin anemia polycythemia sequence. So TAPS is of two types. One is post-laser TAP and one is spontaneous TAP. So post-laser TAPs are more common. This incidence is 5 to 13%, whereas this spontaneous TAPs is 1 to 5%. So what we need to do every time when we see the fetuses, we have to take the MCA PSV and we have to convert it in the mom, and we have to check if there is a discrepancy in the difference is more than 0.5 mom. And then treatment is either intrauterine transfusion or the laser for dichlorinization. Last is the twin reverse arterial perfusion or the TRAP sequence. It is a rare but serious complication in the TRAP sequence. There is normally formed donor twin which has features of heart failure, as well as a recipient twin who lacks a heart and a various other structure. So this is the caused by an embryo by a large artery to artery placental shunt, often accompanied by venous to venous shunt. So in this case, again we do RFA for the recipient twin. If we cut connections from here, the other baby can live as singleton, and it has also a very good prognosis if we identify earlier. So RFA is the route. Last but not the least is the monochorionic monoamniotic twin. When there is a single placenta and a single sac. Antenatal management is controversial. Everybody is very anxiously, they call me that, madam, there is cord entanglement. Do we need to bother? Please don't bother. Because antenatal management, we usually manage these babies every 2 weekly, like how we see for monochorionic twin. They have the highest risk of IUD after 24 weeks, that is as high as 6.2%. And the monochorionic monoamniotic twin should be delivered between 32 to 33 weeks. Like how we fix the data for dichorionic twin and the DCDA twin or the MCDA twin, we have to deliver at 36 weeks. Like that, monochorionic monoamniotic twin has to be delivered at 32 weeks. Cord entanglement is seen in all monochorionic monoamniotic twins. So don't be apprehensive whenever you see cord entanglement. It is normal for them, so don't be apprehensive. It does not contribute to increase the perinatal mortality rate. The timing of delivery, uncomplicated monochorionic twin, elective birth from 36 weeks, 0 days. No increased risk of serious adverse outcome. And continuing beyond 38 weeks, there is increased risk for fetal death. Uncomplicated dichorionic twins, you can deliver between 36 to 37 weeks, not associated with increased risk of any adverse outcome. For monochorionic monoamniotic, we have to deliver at 32 weeks. So when we study all these types of management, what is more important is the chorionicity. First and foremost thing, when we see a twin, in the first trimester itself, we need to determine the chorionicity, and chorionicity. Then only you will able to manage the twins very easily. Thank you so much for your patience hearing.
A very elaborated talk, madam. You have very nicely compiled all the things, very nice, beautiful slides, and such a vast topic. You started from the basic to the end, and it shows your vast expertise in fetal medicine, and you have so many accolades to your so many feathers in your cap, and I must congratulate you for very nice presentation. We got so many take-home messages. Thank you so much, madam.
Thank you. Thank you.
Thank you, madam.
Thank you, madam.
Thank you, ma'am. Thank
sir.
you. It's really very good. Very good talk and crispy. All the take-home messages are very good.
Thank you. Thank you so much, Anurada.
Thank you. Thank
Thank
you.
you, madam. You have covered every aspect of it, madam, and it was very clear. Thank you, madam. Thank you.
Thank
It
you.
was a
Thank
very
you.
nice presentation. So, moving further to the last lecture of this session, it's fetal reduction, its practical aspect and challenges. And for this, I would like to invite Dr. Swati Kumari as the speaker. She is a renowned fetal medicine consultant in Raipur. We welcome you, madam. And to chair the session, I would like to invite Dr. Shushma Verma, madam. She is a Joint Secretary, IFS Chhattisgarh Chapter. Dr. Prakriti Verma, she is past President, IFS Chhattisgarh Chapter. Dr. Pooja Kari, she is Treasurer, IFS Chhattisgarh Chapter. And Dr. Jitendra Behera, a renowned IVF specialist in Odisha. We welcome you all to chair the session. I welcome you, Dr. Swati.
I must take privilege to introduce Swati. Swati is, we can say, first fetal medicine expert of Raipur, and she has got all the importance which we give to the first fetal medicine expert, and he is very cooperative and very approachable. And whenever we talk and we ask anything, she used to give answer and remove our confusions. So, welcome Swati. Please start your lecture. Swati. Swati, are you there?
Yeah, this.
No, she was there. Actually, I saw her.
Yeah, she was there. Just now she disconnected, madam.
Okay,
Her slides are visible.
I will call.
Yeah, she must be joining.
She is here only. Unmute, Dr.
Yes.
Swati. You unmute. Hello.
Welcome,
Yeah,
Swati.
she's joined. Unmute yourself, Dr. Swati. Yeah.
Swati, you are not audible.
She is logging in again, actually.
Swati, you are muted.
Ma'am, she's trying.
हाँ तुम muted हो. हाँ हाँ.
Meanwhile, we can take some questions in the chat box. Any one of the speaker can take this question. It's by Dr. Geeta Agrawal. In combine and test, anti-measurement of both fetus is needed or one. Dr. Preeti, madam. Ready.
Ma'am, please unmute yourself, Preeti madam.
Preeti, madam.
I'm sorry. Yeah. Tell me.
Okay. Ma'am, there is a question in the chat box. In
Yeah.
combined test, anti-measurement of both fetus is needed or one?
For every case, you need to measure both the NT, but in dichorionic twin, we take the NT measurement and the risk separately. But in monochorionic twin, we add both the NTs and we divide it by 2 because they are belonging from the same genetic material. So we are taking a single NT, that is average of both the NT in monochorionic twin. But in dichorionic twin, we are taking it separately.
Hello, am I audible now?
Yes.
Yes, Dr. Swati, you are audible.
Yeah.
You're welcome.
Good evening. Good evening.
Thank you,
I'm
madam.
sorry for the inconvenience. Thank you for the kind introduction. I'll be starting with the last topic of the session, fetal reduction. Now, yeah, fetal reduction, like we all know, what I'm planning is to move the session in these patterns. First is, what is multifetal pregnancy reduction? Why do we need it? And how and when to do it? What are the complications associated? And how do we follow these patients? These are our learning objectives. And by the end of the session, I aim to make it more clearer. Now, what is multifetal pregnancy reduction? Basically, decreasing the number of the fetus. Generally, in the higher order fetuses, that is primarily aimed from triplets to higher order, where we reduce the number to what is our primary aim? The more the number, the more there will be over distension, more the chances of early preterm. And early preterm means all of the fetuses are at risk, all the fetuses are at chances of NICU, prolonged NICU stay. We do not want that. And that is why we reduce the number so that the pregnancy continues for a longer interval and the fetuses have a better prognosis. That is our primary aim. Now, why do we do it? That is the whole chances that if we continue with the triplets or higher order, they are going to distend the uterus. Our uterus is an organ which has a distensibility, which has a capacity to distend. If it goes beyond that, it gives way. There are chances of preterm, that too early preterm. That is, there are high chances of delivery between 26 to 28, 30 weeks. And all the three fetuses are at risk of early preterm related complication. So, we have decided the thin edge sword that whether we should continue with the triplets and have a high chances of early preterm versus doing a procedure called fetal reduction where we reduce the number so that the less number of fetuses have a better chance. Now, who all are the ideal candidates where we choose for the fetal reduction? First and primarily, what we do mostly in our clinic is a triplet or a higher order pregnancy. Nowadays, we are not seeing a lot of more than triplets, higher order pregnancies. We are mostly restricted to triplets actually. In twins, like Madam has already, Preeti Ma'am has already told us that there are chances when the twins can be discordant for anomaly, discordant for aneuploidy, and in those things when the fetus is not having a chance, and it is gonna obstruct the chances of the surviving twin, we can opt for something called selective fetal reduction. It is important when the second fetus is gonna hamper the chances of the first fetus, then we give the second fetus a better chance and we reduce the first fetus. This is a plus minus thing. When twins are complicated by severe medical disorders, in those cases, a choice of selective fetal reduction can be taken. Now, like any other procedure, any other thing in fetal medicine, the informed consent is something which is of paramount importance. It is very important that you inform the patient what are we gonna do, What are we aiming at? What are the pros? What are the cons? It is actually not an easy decision for the couple, because most of these fetuses are generally IVF, ART conceptions. They have already have a long history of infertility. They have a long baggage behind them, telling them that we are gonna do a risky procedure, which is gonna, first, one of the fetus is gonna be reduced in size, and second, there are some complications associated with it, and they have to take that call. So it is always a non-directive counseling. We should always tell the patient that they have an option of expectant management. What are the advantage? What are the disadvantage of expectant management versus versus the option of fetal reduction? What are we aiming with fetal reduction? It is important that there are two things: risk of miscarriage versus risk of early preterm. What we are actually doing with a fetal reduction is a slight increase in the risk of miscarriage, but we are significantly reducing the risk of early preterm. That is something which we are really very, very, very worried about, that this early preterm thing is something which we do not want. Though we are posing all the fetuses are at increased risk of miscarriage, the whole pregnancy loss, but then the surviving ones will have a better prognosis. That is what we aim at. Now, like my all previous speakers have already told, in multiple pregnancy, there cannot be anything more important than chorionicity. Chorionicity is something which determines each and every step of multiple pregnancy management. So one beautiful scan done at 12 weeks can really help you in the whole pregnancy outcome. Now, not all triplet pregnancies, not all multiple pregnancies are dichorionic, diamniotic. There are different combinations, and these combinations actually affect the future outcome and should be mentioned very, very clearly on the reports. Because based on that, our whole process of fetal reduction is dependent. Which fetus to reduce, how to reduce, where to reduce is totally dependent on the chorionicity of the fetus. Again, the type of procedure, how do we reduce? Now that we have decided that, see, we have to reduce. So we have few things we have counseled the patient. We have one very first important thing is to ascertain the chorionicity, whether it is trichorionic, triamniotic, dichorionic, diamniotic, yeah, what is the chorionicity? And then we move forward to the second step. Like my previous speakers have already told, how do we ascertain the chorionicity? The famous lambda sign and the famous T sign, we all know. Based on that, we determine whether it is dichorionic or it's monochorionic. Now, when do we do? Ideally, when should we think of fetal reduction? Earlier, few years back, the process was called embryo reduction. Embryo reduction was something done between before 8 weeks or around 8 weeks, where we used to reduce the embryo. Now, but things have moved forward, and now the process of fetal reduction is ideally done between 11 to 13 plus 6 weeks actually, but can be done within 16 weeks, but generally avoided beyond 16 weeks unless up till it is really required. Why do we do it between 11 to 14 weeks? What is the idea? Why is this the ideal interval? Because first, there is something called vanishing twin that we all know. So there are twins in which there are some twins in which nature takes the call and one of the twins vanishes. This process can take place up till 11 weeks, and we give that time to the nature that if one twin or one fetus of the multiple pregnancy has to go, let it go by itself, and we do not have to do anything beyond it. Second and most important is the aneuploidy screening. Anyways, 11 to 13 plus 6 weeks scan has its own importance. We are doing NT, NB. There are a lot of soft markers that we can assess at this point of time. It is important that biochemical screening is not very efficient in triplets and multiple orders, and your NT remains the sole aneuploidy screening marker. And this remains one of the very important points, that first we have to scan, look for the aneuploidy screening markers, do a good structural survey, look which fetuses are structurally normal, which has any soft marker. This helps us to determine which fetus we have to reduce. To choose the fetus, we need to be absolutely sure that the fetus we are leaving has better chance. It should not happen that the fetus we are reducing will develop something later, and then again things become more complicated. So how do we do it? Again, when do we do it? We have decided. Now next is how do we do it? We have two methods. One is intracardiac KCL, and the other is laser-associated procedures like interstitial laser, radiofrequency ablation, or bipolar cord coagulation. Basically, whenever the fetuses are dichorionic, and that is they have separate placentas, we put an intracardiac KCL, put around 2 to 3 ml of KCL inside the heart of the fetus, and the heart goes into asystole, and that fetus gets absorbed slowly by itself, does not affect the other fetus, and this is the method of choice in the dichorionic fetuses. Since in the monochorionic fetuses, they share the placenta. If we use a KCL, the KCL is gonna go from the placenta to the placental collaterals into the other fetus and gonna affect the other fetus. The dead fetus is gonna send some materials which are gonna neurologically affect the other fetus in long run. And hence, in monochorionic twins, we do not use a KCL and better use normally we use a RFA to coagulate the monochorionic twins. Again, each have its own pros and own cons, and we have to decide very wisely which procedure, which fetus we have to do. Now, again, the most important thing that the patient always asks us, madam, which fetus are you gonna reduce? We have, again, it is a very tough choice to make, and it is a difficult decision to make. First, if it is a trichorionic, triamniotic fetus, that is the most common thing that we see. All three fetuses are, you have done a scan, there is no soft markers, all the fetuses are structurally, aneuploidy-wise are normal. You choose the most easily accessible one. The one you can reach easily, you do that. Generally, we do it transabdominally. We do not use a transvaginal route nowadays. And actually, one which is at the fundus, we choose. We do not try touching the fetus at the cervix, which has a higher rate of miscarriages. Again, DCTA twins, when there is a monochorionic pair and there is another a single one, which one do you do? This one is a very, very, very dilemmatic situation because either you have an option of reducing both the monochorionic one and leaving one single fetus. That is again increasing your risk of miscarriage from 5 to 8%. But and there is one single fetus which is surviving. Or else you can reduce the monochorionic pair, you can reduce one of the monochorionic pair through the laser and keep it as a dichorionic diamniotic fetus. This one again has its own complications. Leaving this, first of all, laser-related procedures have a high rate of miscarriage. You have to wait till 16 weeks, and it is not something which is very easily accessible, little expensive, and a difficult choice to make. The other option is reducing the single one and leaving as a monochorionic pair. Leaving the monochorionic pair again is a very dicey situation. There are 10 to 15% chance that the monochorionic one will go into TTTS trap sequence. There are some complications which are specific to monochorionic ones, and this may lead to complications later. I have experienced all of these combinations, and I've experienced lot of complications associated with each one of them. So I'm telling you, it is a difficult decision to make. Again, like I said, what is the aim of this procedure? The aim of the procedure is to decrease the rate of preterm birth. But like always, this is a double-edged sword. It increases the rate of miscarriages. That means, suppose there is a trichorionic triplet and you continue with the expectant management, you do not do nothing. There is 3% rate of miscarriage, but there is 35% risk of early preterm. And so this 3% is actually not very high. It is this 35% which we are very worried about. What do? Suppose we reduce it to dichorionic twin, that is, we reduce one of them. The risk of miscarriage increases from 3% to 7%. Risk of preterm decreases from 35% to 13%, almost 1/3. That is something which we are looking for, and that is something which we really want. Next is, suppose there are a lot of people who come to us and parents tell that please we want only one, reduce 2 of them. We already have 1 child, we do not want 2 more, please reduce 2 of them. What do? If we reduce these 2 of them, the risk of miscarriage increases from 3% to 10%. And the risk of preterm decreases to 8%, which is pretty good, but this risk of miscarriage, which is pretty significant. So you have to balance this always, that the risk of miscarriage versus the improvement in the preterm is something which we are looking for. Again, what I was talking about, this is dichorionic triplet set, something which we often get in our clinical practice, is we normally put 2 embryos and one of the embryos divides and suddenly it becomes a dichorionic triplets. Now, what do we do? How do we reduce them? Which one to reduce them? Again, this is a tricky situation. If we go ahead with the expectant management, that is, these triplets continue as dichorionic triamniotic triplets, and the risk of miscarriage is around 9%, and the risk of preterm is very high, around 38%. Suppose we reduce the monochorionic twins. We reduce the monochorionic pair, leave as a singleton. The risk of miscarriage is around 13%, which is pretty high. And the risk of preterm is also 23%, which is not very significantly reduced, but it is reduced. Again, if we reduce the singleton, that is, leave the monochorionic one. Do not reduce the monochorion, leave the monochorionic one. The risk of miscarriage is around 18%, which is pretty high. And something which we really avoid, we're leaving the one, and that 18% is pretty high. But here you have to see the risk of preterm is significantly reduced. It comes to 9%. And last one is something which is preferred but not easily accessible, is using the laser photocoagulation and reducing one of the monochorionic twin and leaving it as a dichorionic twin. This has a lowest miscarriage rate of 3%, with a significant reduction of preterm birth by 7%. Now, how do we do it? Like all procedures, we prepare the patient, take an informed consent. We normally do it under the transabdominal route. The transvaginal route is something which we are avoiding nowadays. We do it under transabdominal route, under local anesthesia. We, under the ultrasound guidance, we put a needle. I normally use a 20G needle, and under ultrasound guided, we put inside the thorax, inside the heart of the fetus, and put 1 to 2 ml of KCL. Wait for cardiac asystole. Once the asystole is achieved, you can come back and monitor the patient for some time, monitor the fetus for some times. And again, there are incidences when it can come back again. You have to monitor for that. But in majority of the cases, it is fine. Now, this is the typical case that we encounter in a clinical practice. This is a TCTA triplet with IVF conception, coming to your clinic for elective fetal reduction. This is what we do. We under the ultrasound guidance, this is the fetus we have selected. It is on the top, and here comes our needle. This is gonna go, and this is our heart. The fetus has to, the needle will enter the heart. You put the KCL, wait for cardiac asystole, and come out of it. This is our needle. Needle is going to enter. Whatever said and done, fetal reduction is not a very easy thing, because the fetus is moving and you have to target a very small fetal thorax, and you have to be really patient so that your needle enters the heart and you come out in a single shot. Here the fetus enters. Here the needle enters the fetal thorax. You put your KCL, wait for cardiac asystole, and come back. Just a second. Now this was our typical case. Now this is something second case where we get for something like selective fetal reduction. This was a 34-year female, IUI conceived, had a DCD8 twins, and on a 12-week scan it was discordant for aneuploidy. There was an anti raised in one of the twins with anossified nasal bone and tricuspid regurgitation. We did CVS for them, and ideally we should do CVS for both of them. We did CVS for both of them. One was normal and one came out to be suggestive of trisomy 21. Selective, this one was normal and this one had a raised NT. The report came out to be trisomy 21. We went ahead with selective fetal reduction. This is our needle going, and it will in the whole process of fetal reduction. Okay, how do we follow up? Normally, I see them after 2 weeks to see there is any complication. There are some chances of little bleeding. There are some crampy pains. The reduced fetus will take some time to get absorbed. That absorption takes little time. The first 2 weeks are very, very critical, but you have to explain the patient that the whole process of the whole reduction of the whole dead fetus will take around 6 to 8 weeks. Till 6 to 8 weeks, till the fetus reduces, we have to monitor the fetus. The complications are the most dreadful complication is miscarriage. We have to keep looking for them. We normally give them antibiotics and prolonged progesterone for 2 weeks. Now, what did we learn from fetal reduction? That fetal reduction is a double-edged sword, not an easy decision. It is something that you have to help the other fetuses by giving this fetus, sacrificing one fetus. So it is a difficult decision for the couple, and you have to give them the right amount of time and right amount of information so that they can decide wisely. Consent is very, very, very is an extreme important thing in this. It is important that they choose thinking about everything. And at the end of the day, there is always an ethical dilemma that you are killing a fetus, but you should always keep in mind that this is a big sacrifice that one of them is doing to get the other ones a better chance, and sacrifices normally never fail. Now, there are some interesting experience that I have experienced over a period of some 7-8 years. Some interesting cases that where their fetal reduction was useful and a very important tool. So this was a 37-year primary gravida IUI conception, previous to IUI failures, married for 10 years. She reported to my clinic at 6 weeks of gestation with ultrasound suggestive of triplet pregnancy. She was sent to me at 10 weeks of gestation, and I did not know why somebody sent me. He was sent to me for 10 weeks at fetal reduction actually, but what we have already learned is that we do not do it before 11 to 12 weeks. So this patient was came back at 12 weeks, and ultrasound was suggestive of TCTA triplets with structural screen and aneuploidy screen normal for all of three. So as we have discussed further, we decided to go for we gave them the option of fetal reduction, and couple agreed. So what happened that one of the fetuses were reduced, and the couple came back at 14 weeks to the primary obstetrician, and ultrasound appeared fine with healthy twins. At this point, the clinicians find out that the couple is thalassemia minor and they both are carriers. Now what do you do? We have already reduced one fetus, and now we have found that they are thalassemic. They need the two fetuses. One of them can be involved, or both of them can be involved. What do we do again? So this was a difficult decision. We decided to go for amniocentesis for both the sacs. We did amnio. The report came at 18 weeks, and one of the fetuses was thalassemia major. Now this was something which we did not imagine. What do? We have a prolonged history of infertility, IUI conception, one fetus already reduced, now 2 amnios done, and overall the patient has already had a lot of procedures, and now she is one of the fetuses thalassemia major. Now we decided to go ahead again. The couple was told the option of continuation with twin with selective fetal reduction. They chose for selective fetal reduction, and a difficult reduction was done at 20 weeks. We thankfully to the Almighty, this was all fine. It was followed every 2 weeks and delivered at around 34 weeks by elective LSCS. The baby is now 5 years and doing fine. So what did I learn out of this? That is, it is important to ascertain as much as history, as much as things possible before going ahead with fetal reduction, that anything coming up later on may affect your previous decision. So this was another case. Again, this was a very, very, very precious pregnancy. She was a 45 years primary gravida, IVF conception, donor eggs, previous 3 IVF failures. This time because she had such a bad obstetric history, they transferred 3 embryos. She was already diabetic on OHA. At 6 weeks, the primary clinician had done a scan, and there were 3 separate fetuses with cardiac activity in all of them. At 12 weeks, she was sent to us. It was trichorionic triamniotic fetus with normal NT and structural survey in all 3 of them. We gave them option of expectant management versus fetal reduction, and the couple opted for fetal reduction. The fetal reduction was done successfully, and it was followed every 2 weeks like our protocol, and we showed normal healthy DCDA twins with reduced fetus C. At anomaly scan, both the fetuses were normal and the couple was reassured. They were followed every 4 weeks. And at 24 weeks, one of the fetuses started showing fetal growth restriction with growth centiles and lichar affected. Fetus A was normal in growth and lichar. So as we have already been told that according to ISWAG, SFGR is something where EBW is less than 10 percentile or twin discordance is more than 25%. So now we had a condition called DCDA twins with selective fetal growth restriction. How do we follow? We followed them twice weekly, and at 26 weeks, twin Bs developed severe growth restriction with increased resistance in umbilical artery. Twin A was normal. We did not know what to do. We kept on following the patient. We gave them an option. That 26 week, we didn't have a choice. We told them we just have to follow them. We kept on following them. At 28 weeks, the fetus B, which was growth restricted, was 540 grams with umbilical artery PI still increased and oligohydramnios. We kept on following, and at 30 weeks, it became 700 grams with absent end-diastolic flow in umbilical artery and normal DVPI. Fetus A was still normal. At this point of time, we gave them an option. If you can go for an early delivery where both the fetuses, 1.2 kg and one around 700 grammer, can be delivered, and a long NICU stay can be considered. But a couple opted for expected management with expected poor outcome for twin B. At 31 weeks, it had the same findings, and at 32 weeks, that fetus showed reversal of flow, and at 33 weeks, that fetus had a IUFD, and we continued with the fetus A, which was growing normally, and did an elective section at 38 weeks, and a healthy 3 kg fetus was delivered. And this was a learning experience that what starts as a triplet can anytime end as a singleton as well. So learning point, always explain the couple when you're doing a procedure that we do not know what is going to come later in the pregnancy. Twins have its own complications, and it has to be followed accordingly. This was case number 3, where a 35-year gravida to A1 IVF conception came at 12 weeks with a 7-week scan suggestive of triplets. She came to me at around 12 weeks. She came to me, and she gave a history that she had a reduction 1 week back, but she had no reports. I tried looking for an NT scan report, but they did not have any report. They only told that they had a reduction done. When I did a scan, it would look like a TCTA triplet with fetus C reduced. Fetus A, which was normal, and which is normal structurally and by aneuploidy markers, but fetus B, NT was raised, and there was apart from NT, there were no other soft markers. Structurally, it was appearing normal at present. So what did I learn? You should never do a reduction without doing a scan. Look for the aneuploidy markers, look for the scan, then only plan for a fetal reduction. So what did we do for this fetus? This was the fetus where one of the NT was raised significantly. So since the reduction was done 1 week back only, I did not plan to do it so early again. I called the patient again at around 16 weeks, again did a scan for it, and the nuchal fold thickness was still increased, and other fetus was normal. So what do we do now? We did amnio for the fetus, amnio for both the sacs, and one with the raised NT came out to be monosomy X. And couple was told the same, that one of the fetus is Turner mosaic, and they were given the option whether they wish to continue with the twins or they want a selective reduction. They opted for a selective reduction, and the fetus were followed up. This is the microarray report which showed monosomy X. And they delivered a healthy baby at 35 weeks, and the baby is around 2 years and doing fine. So important point, look for the soft markers, look for the structure before planning a reduction. This was another interesting case. This was a 45-year lady, gravida 2, para 1, living 0. Her previous son had died at 14 years of age due to sudden cardiac arrest. She was a chronic hypertensive, overt diabetic, very high BMI, and she had a 6-week scan which showed a normal gestation, three gestational sacs with fetal pulse and cardiac activity. She was on low-dose aspirin and enoxaparin. How do we follow? She came at 12 weeks. We did a scan for her. All the fetuses were fine. The uterine artery PI was fine, and option of elective fetal reduction was done. Triplets were converted to DCDA twins, and at 16 weeks, things were fine. Post-reduction, things were fine, but her uterine artery PI was rising. At 19 weeks, she developed uncontrolled hypertension. 20 weeks, she was on all kinds of antihypertensives. Still, BP was persistently uncontrolled. There were some signs of end organ damage with raised creatinine. On scan, both the fetuses were appearing normal, but the maternal side was getting compromised. So now since it was a very precious pregnancy, they were not ready to terminate. Somehow we decided that we can give them an option of selective reduction versus very high chances of maternal compromise or termination. They opted for selective reduction, that is to reduce one fetus out of the two left, and we went ahead with selective reduction at around 20-22 weeks. One twin was reduced, and to our utter surprise, after 1 week, blood parameters, blood pressure, everything was coming back to normal. Though she was hospitalized to the whole pregnancy for maternal fetal surveillance, but she delivered at around 32 weeks with a 1.8 kg male baby, and mother and baby were doing fine, which was a very, very, very relieving experience for us. In all of these cases, there were twice reduction done, but something which we could have avoided. In retrospect, somewhere we could have avoided them. This is my last case, one of the recent ones, where a 40-year primary gravida IVF conception with a donor egg, where 2 embryos were transferred, but one of the embryo divided and she became a DCTA triplet. Monochorionic pair was occupying the lower pole and the single one was on the upper part. All the fetuses were normal and normal structurally and aneuploidy. And again, when I told you it is a difficult decision for the parents, we gave them all the options that we can either reduce the monochorionic pair, which we have to do the double reduction, or we reduce a single one on the top, or we can use a laser and coagulate the monochorionic into a dichorionic diamniotic one. The couple were not ready to get reduced to a singleton. They opted to reduce the single one and leave it as a monochorionic pair. We went ahead with the procedure and left as monochorionic diamniotic pregnancy. The pregnancy was fine till 22 weeks when the fetuses developed TTTS stage 2, and things were very difficult. TTTS stage 2 has a high rate of progression and going into poor prognosis. At this point of time, we took the decision of doing a selective reduction with a radiofrequency ablation. We did a radiofrequency ablation at around 24 weeks, and where one of the monochorionic twin with the oligo sequence was reduced. The surviving twin was followed every 2 weeks and was delivered at around 32 weeks with a healthy 1.5 kg baby. So, moral of the story: reduction is a double-edged sword. It is not something which is a very easy decision to make, but one of the procedures which can be a savior in many cases. But you have to choose it wisely and use it wisely. Life is all about choices. Make your correct choice so that you can go to the right path. That is the end. Thank you.
Thank you, Swati, for a very elaborate and informative lecture. And you made all the facts very simple, and your brief facts along with the figures made us to make very difficult decision in a simple way. Because always in cases of monochorionic twins or triplet having monochorionic as well as one single fetus, it is very difficult to decide, because we want to continue as a twin, but we can't continue monochorionic twin because of various complications. So it is very difficult decision, and you made the things very simpler, and what you have discussed, your practical cases are we all are facing in our day-to-day practice.
Thank you.
So it is really sometimes very difficult. Patient went to fetal medicine center and they will ask, "Madam, क्या करना है? बताइए अब क्या करना है?" Really, it is within 10 minutes we need to decide sometimes for the patient what needs to be done.
It is much more difficult for the primary clinician, because actually the decision making comes to them. The patient is not deciding; they will decide. The primary clinician is only going to decide.
Here there is one question in the chat box, though I know the answer, but I want to hear from you whether it is required to fill the MTP form for fetal reduction.
No. We are not terminating the pregnancy. The pregnancy is still continuing. We are just reducing the number. And as of now, this doesn't come under the purview of medical termination. It is a gray zone actually. Termination per se is when the pregnancy is ending. This is not something where the pregnancy is ending.
Very nice. Because we have to take permission for the invasive procedures.
Yes.
And if we are registering ourselves for the invasive procedure and we are giving reports of every invasive procedure, then MTP form is not required to be filled because we are not terminating the pregnancy.
We are just this is a gray zone which is not mentioned anywhere, but by practical definition, this is not termination. Anything else?
Swati, I want to know the complications which you face regularly in cases of fetal reduction.
Ma'am, miscarriage. That is the only thing that is possible, and that is something which is which nobody has a control. It is individual's body, individual's reaction, individual's it's actually God's help that nobody can tell anything. The procedure we do is the same. Sometimes even in the one of my patient who was 130 kgs, where the reduction was really, really very, very tricky, but she came out to be very fine. And there are times when I was very nervous with my reduction, what will happen? They came out to be fine. And there are some time when it is a very easy reduction, you come out within some minutes, you come out, and then they turn up into miscarriage. So this is totally not under anybody's control. It is actually the dead material which is dissolving. So how long will it take to dissolve? How will your body react to it? How will the uterus react to it? Is total every individual's variation.
Have you crossed across any patient with renal complication of another twin?
No, ma'am. No renal. Ma'am, again, see, we all have a risk of having a structural. Each fetus has a risk of structural abnormality. What we do is an early anomaly scan and try looking at the fetuses in as much detail as possible at that point of time. But that point of time, the fetus is only some 40-50% formed. So you cannot expect something happening at 70% to be seen at this point of time. So there are cases where fetus may develop something later on the gestation, and I have not included that case. Actually, I had a case where one of the fetus developed some multiple abnormalities later, and we did a second reduction there. These are again, ma'am, second reduction is something which is a very dicey situation. And we opt only say for second reduction only when we are not left with any other option. Otherwise, we normally tend to avoid it as much as possible.
And regarding the location of placenta, if everything is fine, you said you choose the upper.
I choose the most accessible one which is one where I can enter.
Location of the placenta.
Doesn't matter, ma'am. Doesn't matter to me. Again, see, if I am reducing the monochorionic one, I have to reduce the both of them. So even if I'm obliterating the placenta, it doesn't matter. I am anyway going to reduce the other one also. And if it is a dichorionic way, I am anyway reducing that one. तो दूसरे वाले किसी को टच करने की जरूरत ही नहीं, उस वाले को टच कर भी रहे हैं तो क्या होगा? और ज्यादा इसमें तो वन सिंगल क्लीन शॉट जाते हैं मैम. वन क्लीन शॉट जाते हैं मैम, तो कुछ प्लेसेंटा को इधर उधर करते नहीं है, सीधे जाते हैं तो वो कुछ ज्यादा होता नहीं है.
Very nice presentation, Swati. Thank you so much for a wonderful presentation. I think we are running short of time, Anuradha.
Hello.
Yes, we have to conclude.
Sir, please, if you want to ask a question, then please ask.
Doctor, Akshay bhai.
For the fetal reduction, we need any specific certificate from PCPNDT side?
No. Same invasive, when you apply for an invasive, you have to write all the things that you want to do and you can mention it over there.
No, but when you are applying, if you will go to the form, we cannot write anything while online portal, we cannot write anything.
No, sir. Again, there are some, I do not remember exact the headings under it.
That fetal reduction word is not there. Actually,
sir, again, fetal therapy, if you are doing, it comes under fetal therapy only.
Okay.
So again, when we take we do not take permission for specific procedures. We take either whole invasive and fetal therapies.
Okay, no, invisible, if you go through it, Form A, it was written
Sir,
amniocentesis,
others, एक
Korean.
last में column there is a others.
Okay.
हाँ,
So,
what actually again this form was earlier we had only few of the procedures, so they have mentioned few of them and not written anything else and wrote others. But now we have lot of procedures and they cannot write each and every name. So what here what
okay,
happens
so
is they give you
if,
permission for fetal
so,
therapy.
okay, no,
Huh.
I am asking if we have invasive certificate, we can do it.
Yes, sir. Yes, sir.
It is
Okay.
while applying for the PCPNDT either renewal or new license.
New license.
You have to make it
Okay.
clear whether you want to do invasive testing or not.
Okay, if invasive is there, we can do it.
Invasive, we can go for fetal reduction, amniocentesis, CVS and everything.
Anything.
PGTA also.
Again, sir, PGTA is something little different. PGTA, you need a certification from the lab, what lab you are associated with it, who is going to do it, the embryologist. There are criteria for that. And PGTA is associated
Okay,
with
thank you.
ART rules also. So we have to get permission from all of them. Then वो कुछ criteria है सब PGTA के लिए.
Yeah, Dr. Swati, very nice presentation. I think you might have cleared all the scenario
you.
what we are facing as a IVF specialist day to day. I have a doubt, one single doubt, like you told regarding the fetal reduction in 11 to 13 weeks. So why not we will make it to patient for the entire 12 weeks around? And that also has been instructed by so many of fetal medicine, because sometime the patient will go, the CRL will be not corresponding, and then again they
Sir,
have to
I
send us
normally
back.
do it at 12 weeks only. Precisely
Yeah.
speaking, this is what is written in the books, but frankly, in my clinical experience, I do it around 12 weeks only. When I am very satisfied with the NT, when I am very satisfied with the whole thing, then only I go ahead with imaging, with a reduction. I prefer doing it at around 13, 14 weeks also, rather than doing it at 11 weeks. When the fetus is little bigger, it is very easy to access the fetus.
Yeah.
The smaller fetuses, it is unnecessary
Yeah.
making a life difficult. And frankly speaking, as a fetal medicine person, I do not like doing it at around, I get reference for doing it at around 10 weeks also, 11 weeks also. I do not like to do it. I like to do it
Yeah.
around 12 plus weeks only.
Yeah,
But
yeah.
majority
So-
of patient में क्या होता है sir, IVF patients are already on enoxaparin, already on
Yeah,
Ecosprin.
yeah,
So
yeah.
when they come to me, I stop that thing and then they come to me, so they become 12 weeks by that time.
Yeah.
What is your
And
opinion regarding twin to singleton?
Again, sir, I put it across the data to the patient, and patient takes it call. I have done it, reduced both the monochorionic ones. I have reduced two of them, reduced one of them. But again, it is totally patient's choice. Hana, it
No,
is
no, no. What I am
because I am
asking,
telling, because fetal reduction is not like amnio or CVS, whether the risk of complication is very less. This is something which is a double-edged sword, and always it is important that the patient takes a choice whether they want to go ahead, because later on if something happens, it should be a
no,
shared
in
thing.
case of someone has a twin pregnancy, she had a child. She
So
had,
we can
she
go
had a
ahead, sir.
child.
We can go ahead. There is no guideline as such that we cannot reduce twins to singleton. This can be done, but again,
Child previously, she
by
got a conceived kid to singleton. What is your
yeah,
opinion?
you
You will
can do it,
go
sir.
ahead,
It is okay.
or you will.
Nowadays, a lot of couples are coming up.
In my experience, in my opinion, in Chennai, they usually Mediscan they refuse it.
Sir, by all scientific data, reducing twins to singleton doesn't make any sense, because twins are already gonna make to 32 to 34 weeks. Both the twins are gonna have a good prognosis. Again, sir, it is parents' choice. If they are very sure about it that they do not want to continue with a twin, they can opt for it. And I have done it for few of the times, sir. Though I do
so
not encourage it.
is there
I
any
do not
indication
encourage
like
it.
patient request? Indication like patient request, like we can write as per before reduction.
No, sir, I write it. It is
Indication
parents'
is the
choice. I write
patient
DCDA twins if
request.
parents want fetal reduction.
Like that.
No, it said there's nothing wrong about it. See, couple may opt for termination, right? There are couple who may have
Yeah,
two,
okay.
3 kids, and they may
Okay.
opt for termination. This is something it is their
Yeah.
choice, and they are ready to take the complications. I explained them what are they going to undergo, and this is their choice that they want to discontinue one of them.
Thank you, Dr. Swati,
Thank
for
you.
a very elaborate and thorough discussion. I hope you all had a fantastic time for attending this amazing webinar on early pregnancy and its complications related to twin pregnancy. And I thank everyone who participated in today's webinar, and I appreciate the speakers' insightful
And
presentation
like in IVF, like
and
always, we used to
organizers'
maximally the MC.
hard work in making the event possible. Thanks a lot for enlightening lectures by our respected speakers and insightful scientific inputs by our respected chairpersons. Thanks a lot, SIG Early Pregnancy and Odisha chapter of IFS for including CG-IFS in this webinar. Thanks a lot, everyone. And thanks a lot, Corona, for providing us a digital platform.
Thanks to Raigad IFS Raipur chapter to be as part of involving us in that. It is a good CME and good knowledge sharing, and we learn so many things. Thank you all.
Thank you, Anuradha madam, for the
Thank
opportunity.
you.
And
Opportunity.
Thank you each
this.
and everyone for joining and making this webinar.
Really, Anuradha, the topics are very nice and very practical.
Yeah.
I must congratulate you for
Thank you. This
such
is a
thoughtful,
teamwork
keeping
and
such
hoping.
thoughtful topics.
Yeah. And hoping for the same again in the next month.
Thank you,
So
Anuradha
good
ma'am.
thing.
Thank you for the
Thank you.
opportunity.
Thank you all the speakers, all the chairperson and all the president secretaries of all the societies to come nearer and share the knowledge. And again, we will do again in the next month. Thank you again. Thank you, Corona, to give the platform for this webinar.
So I'm leaving the meeting.
Leaving.
Okay.
Leaving.